Thank you, Mr. Chairman. Good afternoon, ladies and gentlemen. The prevalence of coronary artery disease in patients with aortic stenosis undergoing TAVR, this is the TAVR population, is significantly high, and the prevalence depending on the definition of the coronary artery disease, goes from around 34% to up to 75%. And very recently, we have this real-life data from Denmark, East Denmark Heart Registry, showing almost the same results. As you see here, one vessel disease is around 25%, and altogether, the normal coronary or no coronary artery disease is 40%. In this registry, again from another Nordic country, Sweden, this is a surgical registry and related to the patients who underwent coronary bypass surgery and surgical aortic valve replacement. And as you see in the chart, the prevalence of coronary artery disease goes up with the age, and also the presence of calcification in the valve. An aortic valve calcification now has been thought to or could be a marker for atherosclerosis of the coronary arteries. Well, so far, everything almost clear and established for surgical aortic valve replacement. We have the established indications for coronary angiography before surgical aortic valve replacement, and guidelines recommend that the concomitant revascularization should be performed in case of significant coronary artery disease. However, this is not the case for patients who are candidates for TAVR. Here I show you a list. It's not for reading, but just to show you a lot of different type of studies and registries, and with indeed conflicting results about the impact and prevalence of coronary artery disease on the outcomes after TAVR. Here I have picked up one meta-analysis for you, and this is a very large cohort, again by Samir being the senior author in this meta-analysis, over 8,000 patients with aortic stenosis undergoing TAVR. And in this meta-analysis, the coronary artery disease was ranging between 38% to 78% in different studies. And interestingly enough, the authors found no effect of the presence of coronary artery disease on 30-day all-cause mortality, but when they went to 1-year all-cause mortality, there was a 20% increase with the presence of coronary artery disease. This is another interesting pickup, a study from Bonn, Germany, and shows us the importance of the extent of and severity, anatomic severity of the coronary artery disease and relation to the all-cause mortality. As you see in the curves, the mortality is related to the severity of the coronary artery disease. Well, with this data, it seems that we need to reduce the myocardial ischemic burden through PCI, and in fact, this could be a legitimate option to improve clinical outcomes after TAVR. But in the meantime, I would like to bring another interesting issue to your attention, angina as a symptom. Well, of course, the elderly people or elderly patients with severe aortic stenosis complaining of angina frequently exhibit concomitant coronary artery disease as well. And of course, in such cases, whether myocardial ischemia is determined by insufficient oxygen supply due to the underlying valvular disease or due to the presence of coronary artery disease is a matter of debate. And in fact, we know now from the recent studies that coronary blood flow and vasodilator reserve are really disturbed in aortic stenosis, and immediately after the TAVR or the aortic valve placement, these are actually reversed, and the patient symptom is usually relieved. Sometimes it is also the fact that the clinical manifestations of these two situations may overlap, and it may not be so easy to really discriminate whatever the underlying cause was. But in any case, in this, the recent ESC/EA CTS guidelines on myocardial revascularization recommends that PCI should be considered in patients with a primary indication to undergo TAVI and coronary artery diameter stenosis over 70% in proximal segments. But please note that this is a class 2A recommendation, but the level of evidence is C. On the other hand, the ACC, AATS, AHA appropriate use criteria document also really declares that the intervention to the coronary arteries in symptomatic patients before TAVI or who in TAVI candidates is appropriate. Well, there are two key questions in the management of patients with aortic stenosis and coronary artery disease. One is, first, is the coronary artery disease significant enough to perform an intervention? Of course, to understand and decide on this, you need to evaluate the clinical aspects, anatomical assessment, as well as our chairman mentioned some physiologic assessment if you need on the road. And of course, the second and another important question, still debatable, is if a PCI is necessary, what is the best timing for PCI? Here I put together all the pros and cons for the three different stages of PCI intervention: before TAVR, concomitant PCI during the procedure, or PCI after TAVR. As you see in the table, each approach has its own pros and cons. For example, if you do it concomitantly, you can do it, but in this case, the patient may have an increased risk of contrast nephropathy, and the procedure will be longer, and the radiation exposure may be increased. In many institutions like us, the PCI is usually performed before TAVR. However, as I mentioned earlier, there are always concerns about the cause of angina, whether it is due to the aortic stenosis or due to the presence of coronary artery disease, and some centers or some operators would like to wait a little bit to see whether the symptoms will be relieved by TAVR or not, and they will go to post-TAVR PCI. Of course, this approach has some difficulties and limitations, and it's not so easy to access the coronaries, particularly in the self-expanding valves, and you may need to have special preparations with CT, and you may also need to use special catheters. This is ACC recommendation or an algorithm from the Section Leadership Council of ACC for PCI in TAVR. As you see, very simply, if there is no significant coronary artery disease, it's straightforward, you can proceed with TAVR. But if there is significant coronary artery disease and it is proximal epicardial, shouldn't be endocardial, epicardial vessel or left main, then of course, if it is doable, technically, you do PCI before or concomitant during the procedure. If it is non-proximal or branch vessel or CTO or with a small area, myocardial area at risk, then you have to evaluate the patient's symptoms. If you think that the symptoms are related to the coronary disease, then you go for PCI. If not, you can again follow the patient. Here I have just a sample case, very high risk, again, with a history of previous coronary artery disease, therefore really deserves having a coronary angiogram before the procedure, and she also had previous stroke, etc. And here we had this two-vessel disease, and we performed PCI before the procedure. Usually I proceed within a week time, just to give some time for kidneys to recover if the patient's condition is really convenient for such a waiting time, and then we proceed for TAVR. In conclusion, Mr. Chairman, ladies and gentlemen, coronary artery disease and aortic stenosis frequently coexist. The presence of coronary artery disease has been associated with impaired prognosis in patients undergoing surgical valve replacement in short and long-term follow-up. This is a well-known fact, and accordingly, current guidelines recommend coronary artery revascularization of all significant stenosis in patients undergoing surgical aortic valve replacement. However, the management of concomitant coronary artery disease in patients with severe aortic stenosis undergoing TAVR is still a matter of debate, and with the currently available data, patients with coronary artery disease undergoing TAVR will need to be evaluated by a multidisciplinary heart team and receive individualized management based on their clinical and angiographic findings, and staging PCI either before or concomitant with TAVI appears feasible. Optimal timing should be decided at the moment on an individual basis. I thank you for your attention.
Thank you very much, Professor Otto, for the excellent talk. I suppose absence of angina is a good reason not to revascularize moderate lesions. Is it correct? In these patients?
We don't usually rely not only the clinical parameters, but also the other parameters. We usually have the imaging data from CT. As you know, the CT is very good in terms of negative prediction. If it is good, you feel yourself comfortable. I just did the same, the case that I showed you in my previous talk, the dual valvular intervention. So in that case, despite the age of the patient, the CT showed no critical lesion, no calcification in the coronaries, so we didn't really do coronary angiogram even.
Thank you very much. Dr. Dimitriadis, short comment.
Thank you. You elegantly presented how to deal with coronary artery disease before or during a TAVI procedure. Now there is a problem how to handle coronary artery disease after you have implanted a valve. And there are some online material helping us to position the valves, also with CT analysis. So do you think that For this purpose, the balloon expandable valves have an advantage over the self-expandable valves. And coming again to the lower risk, long life expectancy patients, do you think that maybe we should trade off the one towards the other?
Well, very important point. I just touched, because of the time, I didn't really go into the details of the post-TAVR coronary angiogram. Well, it's been repeatedly shown that it is feasible, it is doable, but as you mentioned, there are difficulties in several levels. First, the type of valve, again, as you mentioned, it is always straightforward, or usually straightforward, I would say, with the balloon expandable valves to access the coronaries. But it is always tricky, sometimes easy, sometimes you may really get into trouble with the self-expandable ones. But still, there are some tricks in the implantation procedure. If you, well, you never know, but now we are just going down to the low-risk patients. That brings the really the higher probability of having more post-TAVR angiogram and management of coronary disease after TAVR. So probably we need to find a really optimal implantation way to just allow you or to ease your access to the coronaries. You're right.
Professor Otto, thank you very much for the excellent talk again.